Hello, my name's Dick Clarke, and some time ago I was asked by the BNA if I would present at their regular webinar series. I agreed to do so, and actually gave this talk on Thursday, September the 13th, entitled Healthcare Worker Decompression Sickness, Incidence, Risk, Mitigation. A couple of days after my talk, I was advised that the recording didn't take place, and I was asked if I could re-record this so that those of you who were unable to come in for the live presentation can get a hold of this by video streaming from the BNA in the future. So I agreed to do so. So here it is a second time round. I have no financial conflicts of interest related to this presentation. And in the time available, I'm going to summarize some of the key points from this recently published review article. The paper provides a much greater in-depth treatment of the topic, and I've included extensive references that will be discussed in part during this presentation. I've sent the paper over to the BNA, and they've advised that it's available through the BNA if you want to get a hold of it. Those of you that work in a multi-place chamber setting, particularly the inside attendants, I would encourage you to indeed get a hold of this paper and read it in detail. Perhaps the most important message I have for you in this webinar is for you to grasp the distinction between incidence and risk. Incidence is the common metric employed most of the time when talking about decompression sickness and inside attendance. And you see here that incidence is calculated as the number of inside attendant DCS cases over the number of hyperbaric exposures during any given study period, or more simply, the potential for a case to occur during any given exposure. And not surprisingly, the incidence is exceedingly low. In most cases, it is less than 0.5%. So quite a number of practitioners argue that with such a low incidence, this is not really a very worthy topic. However, risk, on the other hand, has all but been ignored, and risk is defined as the number of cases of DCS over the number of inside attendants working during that reporting period, or more simply, the likelihood that any given inside attendant may suffer a case of decompression sickness. And you're going to see very shortly that this risk is much higher than the reported incidence. So this is an important distinction, particularly if you're the inside attendant. I suffered 2 of my 5 cases of DCS, one as an inside attendant and one as a diver medic. So this is of personal interest to me. Okay. What I thought I would do is to put a personal human face on this particular topic. So I'm going to dedicate the webinar to 2 known hyperbaric nurse inside attendant fatalities. Family members and friends that I contacted were very pleased to hear this because they felt that their deaths did not really get the attention they deserved, and arguably perhaps because both of these deaths occurred prior to 1996, at which point the Joint Commission introduced their sentinel event policy. Family members kindly provided photographs of these 2 nurses, the first of which is Joyce Vors. And Joyce was a 53-year-old at the time. She worked in a part-time capacity as an inside attendant at Baromedical Center in Panama City, Florida. She worked full-time as a nurse on the OBGYN floor at that hospital. Her story was that she exited the chamber following a treatment table 6A, that's the 165-foot treatment pressure, 6 atmospheres absolute. It was a very lengthy exposure in the chamber. She'd been in there for about 13 hours with a very seriously injured diver. Immediately upon exiting the chamber, she complained of pulmonary discomfort and developed something of a persistent cough. Very regrettably, she was allowed to depart the hospital without any formal assessment of her state. She was found deceased at home in her shower approximately 90 minutes later, and her autopsy was consistent with overwhelming decompression sickness. The principal factor as to why this occurred was the lack of experience in the operational team. The technical director, who had been there for quite a long time, was very capable. He had recently been let go as a cost-saving measure. The person replacing him was less experienced and made an error in providing Joyce with air through her oral nasal mask at 165 feet instead of nitrox, 50% oxygen, 50% nitrogen, which would reduce her nitrogen uptake accordingly. There was clearly no inline oxygen analyzer because it would have been alarming if it was showing 21% versus 50%. And this actually for Joyce was a repetitive dive. She had made a dive on a wound healing treatment in the morning before, so that compounded her nitrogen uptake. So the bottom line here is this was obviously a misdirected cost containment strategy, and what was rather ironic was that several weeks before her death, the hyperbaric medicine director had written a letter to the hospital very frustrated about several aspects of the hyperbaric program, and in part he wrote that I would like to convey as strongly as possible my concern regarding the lack of technical expertise at the chamber. And as you might imagine, that statement featured very prominently in the subsequent legal proceedings following this tragedy. There was also a failure on the part of the hyperbaric medical director in not assessing Joyce when she became symptomatic exiting the chamber, not trying to determine what was going on, and then if recognizing decompression sickness, get her back into the chamber. All that failed to occur, very sadly. The second event occurred some 8 years later, and arguably this was even actually more tragic, if you can believe that. This is the story of Mary Ann Isdale, and she suffered her decompression injury in April of 1999. At the time of that injury, she was a 43-year-old, and she was actually a full-time hyperbaric nurse chamber operator and inside attendant. And her story is even less well known than that of Joyce due to the manner and the timing in which death occurred. She was employed, Mary Ann, at Los Robos Medical Center in Thousand Oaks, California, and they had there a couple of these Renault chambers. I wonder if any of you are familiar with this chamber type. It was somewhat popular in the 1980s because it represented a bit of a compromise between the monoplace in terms of its footprint, its size, and the multiplace chamber in that it had a inside attendant capability. You can see in the right hand image a depiction of a nurse in the small entry lock at the right hand side of the chamber. It also was able to go to 6 atmospheres absolute. So that was the particular chamber type. And on this case, again, Mary Ann had attended an injured diver. The treatment was initiated on U.S. Navy treatment table number 6, so that's 60 feet, 2.8 atmospheres absolute. Excuse me. The diver had a generally poor response at that particular pressure. The diver had been there for 25 minutes, and so the order was given to compress the diver slowly to 165 feet of seawater. It took 35 minutes to arrive at 165, so Mary Ann's bottom time upon arrival at 165 and before any time at 165 was already 1 hour. She spent 20 to 25 minutes at 165 feet, and she was breathing air throughout. There was no facility at this institution for the inside attendant to breathe nitrox to both limit the amount of nitrogen that was uptaken and also minimize the complications of nitrogen narcosis. She actually struggled significantly during this particular treatment with nitrogen narcosis. Those of you who are preparing to take a CHRN exam, you might want to at some point compute the decompression obligation for Mary Ann with an exposure to 165 feet for 90 minutes of bottom time. Then add another 4 hours of bottom time for the time that Mary Ann spent at 60 feet before surfacing, and you'll see it's pretty much off the charts. The chamber was eventually ascended to 60 feet. The patient was starting to improve, and it was felt that Mary Ann was no longer required, and she was locked out of the chamber at that point. Immediately upon exiting the chamber, she too developed a persistent cough. She thought it was an asthma attack. She happened to be an asthmatic, so she used her asthma reaction kit without any effect whatsoever. The hyperbaric physician did not immediately recognize what was going on as she developed onset of lower extremity and then upper extremity increasing weakness and distress. It became apparent soon thereafter that she was suffering decompression sickness, and she was recompressed down to 165 feet of seawater to start at table 6A, which was not a really wise thing to do. She did not respond. She failed an aggressive course of HBO therapy over more than a week and was left with a permanent state of complete quadriplegia. She developed pressure ulcers over time, as these patients tend to do, ongoing infections, and she eventually succumbed to overwhelming sepsis about 8 years after her decompression injury. So this fatality was sort of buried in the concept of an inside attendant injury. For several years, Mary Ann was omnipresent in her wheelchair, lobbying unsuccessfully outside the California state legislature's offices for stronger health care accountability laws and better compensation for victims of medical misadventure. Now, how did this occur? This again was a misguided attempt at cost containment. That hospital in question had been acquired recently by a for-profit hospital chain, and they instituted a number of cost-cutting measures to improve the profit margin for the hospital. One such measure was to fire, essentially, the experienced medical director. He was getting $100,000 a year stipend, and they thought they could save that by getting him out and replacing him with somebody else that was a lot less expensive. And unfortunately, that replacement, an orthopedic surgeon, his only claim to fame in terms of hyperbaric medicine was that he owned a scuba diving shop. He had no training in hyperbaric medicine. The hyperbaric medicine team, the nursing team, they had relied entirely on the knowledge of the initial physician, who was indeed experienced, because they were never allowed to travel out of that hospital to get formal training. So when this event occurred, the new medical director was very challenged. He didn't really understand what was going on, and there were several errors made in this particular process. To add to the devastation of this particular fatality, the chamber operator, a nurse who was operating the chamber at the time of Mary Ann's accident, felt quite responsible for that accident, even though she was following the orders of the physician. She visited Mary Ann in the rehabilitation center on occasion, and she became eventually overwhelmed with remorse that she actually took her own life as a direct consequence of that fatality, incredibly sadly. Okay, with that as a sort of preamble, we'll get to the meat of this presentation. And this first piece of information was generated by Christy Peroni. Christy was an early BNA member in Indianapolis. She emigrated to Adelaide, Australia, and amongst other things, she took on the Hyperbaric Incident Monitoring Survey project. This was an anonymous reporting process for chamber operations and staff. It had an international flavor to it, and this was her first report of the data accumulating in that anonymous database. It was reported at one of the Hyperbaric Society meetings in San Antonio in 2002, and you can see that in the listing of categories of incidents, accidents, and near misses, 17% of those involved the inside attendant. The inside attendant, like the patient, suffers potentially barotrauma with pressure changes, but unlike the patient, the inside attendant suffers decompression sickness. And there were several career-ending cases reported in this particular database, one of which, ironically, was that of the author of this particular report. A more recent report from France represented a 7-year analysis of accidents and injuries involving inside attendants. It was a survey sent out to all of the known hyperbaric chambers in France. 73 inside attendants responded, 27 of which reported at least one adverse event while in the chamber, and decompression sickness was second only to ear barotrauma. Now, what I've done in terms of hyperbaric chamber pressures and indications, I've broken them down into two distinct settings. The first one is the dosing protocol used, or dosing protocols used for the treatment of decompression injuries. And you can see here that the standard, the international standard, is United States Navy treatment tables 9, 5, 6, and 6A. You'll soon learn that aside from those two fatal cases, there's much more morbidity associated with US Navy treatment table number 6A. That's that 165-foot pressurization. Thankfully, the use of this table is uncommon today, and in my view, it was far too frequently used when it was actually not medically necessary. So the really good news for the inside attendant treating a case of decompression illness, today at least, is that the US Navy have evolved protocols to be highly effective in protecting the inside attendant during decompression. Essentially, every new edition of their diving manual added periods of oxygen breathing, extended periods of oxygen breathing on the previous version. And today now, these are very, very robust treating protocols. You're looking here at the latest edition, which is the U.S. Navy Diving Manual 2016, December the 1st, its publication. And anybody inside the chamber treating a diver should be decompressed based on these criteria. The Navy have been very successful. I actually wrote a letter to the Department of the Navy under the Freedom of Information Act request, and I asked if they could give me the incidence of inside attendant decompression sickness in the Navy using tables 5, 6, and 6A, and for beginning in 2006. Because that's when the last evolution of that extension of oxygen breathing occurred. They wrote back and said very impressively that the incidence was 0 on those tables 5, 6, and 6A. They did, however, note that there was one case of inside attendant decompression sickness on U.S. Navy treatment table number 9. Some of you may not be as familiar with this table. It was introduced in the 1999 edition of the Diving Manual, and it's designed specifically for follow-up treatments of decompression sickness with incomplete clearing. Commonly, we've tended to use table 5, but table 6 table 9 is far more preferred. And in this particular case, the inside attendant had been in the chamber with a non-diving related clinical indication on table 9. He decompressed, went straight to the gym, and had a strenuous workout, and it was during that workout that he became symptomatic, and I'm sure that strenuous workout post-ascent had something to do with it. We have no information on this case as to whether it was a repetitive dive for the inside attendant, whether they breathed oxygen during the decompression, but for those of you that are not as familiar with it, it's listed here, and the multiplace chamber personnel will probably recognize that very readily as your standard 2.4 ATA or 45 feet of seawater for 90 minutes standard treatment protocol for multiplace operations in the clinical setting. Again, strongly recommend that this table be used in follow-up for incomplete clearing of decompression sickness. I actually wrote a letter to the editor of a journal as to why this is preferred over table 5. It's a lot safer than table 5 for several reasons, and that letter is actually on file also with the BNA. So if you want to learn more about that, go ahead and ask the BNA to get a copy of that. So with all that aside, the decompression sickness side of the equation now is in good shape from a decompression sickness standpoint with tenders. I'm now going to concentrate on the clinical applications of HBO therapy and produce a series of recommendations. So this first report on the clinical side of the equation comes to us from Virginia Mason Medical Center. It was published as a abstract at the UHMS meeting in 1992, and the objective of this particular analysis was to look and see if there was any gender-based risk of decompression sickness. There'd been a suggestion perhaps that females might be more susceptible, but this data found no difference in the incidence between males and females. They reported on almost 8,000 treatments over a 15-year period, and during that period there were 26 cases of inside attendant decompression sickness, which produced an incidence of 0.31. Okay, so that's obviously very, very low. Missing from this abstract was information about how many inside attendants were employed that would give you the risk. So I actually made contact with the institution in question, and they were able to say that during that study period of those 8,000 procedures, it was estimated that between 20 and 30 inside attendants were employed. So what do you think that implies? You do the math. Risk, remember, is the number of cases of decompression sickness over the number of inside attendants, right? So 26 cases over 20 to 30 individuals provides an employee risk of about 100%, that every one of those individuals will suffer decompression sickness at some point during that review period. Now, in actual fact, not every individual suffered decompression sickness, because some suffered it more than once. So at first blush, this paper suggests there's little to worry about inside attendant wise, unless you're the inside attendant and you understand the distinction of risk versus incidence. The second large retrospective came from the Baltimore Shock Trauma Unit. This was a much longer period. This was 23 years of retrospective involving over 25,000 hyperbaric procedures. Again, it was presented as an abstract. You can see on the left-hand side at the 1995 UHMS meeting. Sadly, it never found its way into a full paper in a peer-reviewed journal. I did happen to get a hold of the paper in question that was never published, so it provided a lot more information there that was available in the abstract. They noted that between 1969 and 1985, almost all the treatments were rendered at 45 feet of seawater, that the inside attendants were decompressed in accordance with U.S. Navy air diving tables, i.e. No oxygen during decompression. During that period, the patients were breathing O2 by mask, and this group had actually measured oxygen delivery in the masks, and it got as low as 88% in some cases. In 1985, late 85, they switched to a head tent, and of course measured oxygen levels then were exceedingly high, as you might imagine. The head tent's a sort of mini monoplace chamber around the head and neck. Because the pressure was oxygen percent was so high now, they felt comfortable decreasing the treatment pressure to 33 feet of seawater, or 2 atmospheres absolute. And that's interestingly where most of the establishing data for the treatment of wound injuries, non-healing wounds, actually occurred at 2 ATA oxygen. Okay. This group, like others, recognized that you could not produce 2 ATA oxygen with a face mask at 2 ATA chamber pressure, because you look above and see that O2 level is much lower. Dalton's law dictates that at 2.36 with 88% oxygen, you're breathing about 2 ATA oxygen. So they dropped it to 2 ATA with a hood on, but they did not adjust the decompression schedule. Those inside attendants came out only breathing air. And you can see that the initial incidence of decompression sickness was halved in the subsequent incidence by dropping from 45 feet to 33 feet. And if they had breathed oxygen during the decompression from 33 feet, arguably that would drop to almost zero, that incidence. In the main paper, they'd helpfully broken down the incidence with the chamber pressure, and you can see from 33 feet to 45 feet, there's a doubling in the incidence. There's a doubling again when we go down to 60 to 66 feet, and there's more than a quadrupling of the incidence upon arrival at that 165-foot table. 19 cases of DCS occurred in 13 attendants, and so that was an overall incidence of less than 0.1. But there were 439 attendants in that study period, so the individual risk was over 4%. And that paper also noted that there were 120 inside attendants took care of almost 98% of all exposures. So doing that same math to define risk, the actual risk for these individuals was almost 16%. Researchers in Turku University in Finland, they reported their experience with inside attendant decompression sickness, and it was somewhat unique. For 30 years, they had actually operated with a monoplace chamber. The university eventually acquired a multiplace chamber and installed it, and these practitioners quickly recognized that there were no established consensus opinions on what the decompressions of these inside attendants should be. You can see from 1992 to 1996, all the treatment pressures involved 2.82 atmospheres absolute, or 60 feet of seawater, very, very high. And the principal reason for that was this was the home of Dr. Nini Yankowski. Some of you may recognize that name. He was a disciple of T.K. Hunt at the University of California, San Francisco, and an early, very prominent researcher in the role of HBO therapy in gas gangrene and necrotizing fasciitis. So he wanted to maximize the antimicrobial effect of hyperbaric oxygen by using that very high pressure. There were 43 attendants at the time of that study period. 2 obvious cases of DCS were reported. They were actually spinal cord injuries, and so they actually added oxygen breathing during the decompression. Their initial decompression of the inside attendants was based on the Finnish naval air diving tables, which were clearly not adequate. So after those 2 obvious cases, they used the Finnish Navy decompression tables, but they added oxygen breathing. They also reduced the pressure to 45 feet of seawater. Interestingly, they had another very severe case of decompression sickness, and so they introduced oxygen breathing initially upon arrival at 60 feet. You can see that double line next to 15 meters showing 10 minutes of oxygen breathing, and then the double line showing the decompressions on the way back to the surface. What's interesting about that oxygen breathing when you get to pressure, obviously you denitrogenize a little bit when you're there, and this can be helpful in the setting of a sudden requirement to abort the chamber treatment and bring the chamber back to surface pressure. That might be because of a major problem with the patient and they need to get a code team to them. It could be some technical problem with the chamber or the like, and they have to abort the chamber treatment. So that is always the great concern for the inside attendant, is to be brought quickly back to the surface without the decompression strategies that have been put in place to protect that individual. A bit more on that as we get later into this talk. Even with that previous decompression schedule, they had another case of spinal cord decompression sickness in the staff member. So what they did is to actually divide the exposure or treatment period into 2. One inside attendant would be in the chamber for the first half of that 90-minute period, and then they would be replaced by a second attendant for the latter half. And obviously that greatly reduces the uptake of nitrogen, but requires obviously a lot more staff members in rotation to be able to accommodate that. They were pretty frustrated with these cases of decompression sickness, and they set out a plea for authoritative organizations to address this issue in a more formal manner. And in fact, the European Consensus Conference took place about 7 years later, and they did indeed address the issue of inside attendant decompression sickness. And amongst other things, in their summary, they noted a linear correlation between increasing pressure in the chamber and increasing incidence of decompression sickness. They emphasized in this report the importance of oxygen breathing, not relying solely on the air decompression tables, and also the need for some form of medical fitness for the inside attendant to mitigate against the incidence of decompression sickness. Unfortunately, they provided no specific guidance or standards, which was really an opportunity lost by this important body. Their conclusion was that inside attendant activities were safe, so seemingly oblivious to that employee risk calculation that you're now very familiar with. A little closer to home, this is a report from Catalina Island, California, a USC affiliate, and this was again a meeting abstract and focused attention on the issue of treatment aboard, having to abort a chamber treatment and concerns about the inside attendant not being able to be afforded what was initially planned for their decompression. They reported 3 cases of inside attendant decompression sickness following 500 exposures, all at 165 feet of seawater, U.S. Navy treatment table 6A, and they listed here the reasons why they had to abort the chamber treatment and bring that individual out. And they felt as a result of this, in these 3 cases, they needed to add additional oxygen breathing if they had time to do that, i.e. the chamber did not have to come back dramatically to resuscitate an individual that could not be managed adequately inside the chamber, or there was a technical problem with the chamber system itself. One statement they had there, that major recommendation, was if the inside attendant had an hyperbaric exposure in 12 hours prior to going into the chamber in this setting, that they should probably add another 60 minutes of O2 breathing at the 30-foot stop. And what was kind of interesting is the evolution of the U.S. Navy Diving Manual oxygen breathing guidelines indeed incorporated both of those 2 recommendations there made that time earlier. Here's another case of a decompression sickness occurring in inside attendant because of an abort of the chamber, having to bring the chamber back to the surface. And this involved a very seriously injured diver, suffered a gas embolism, was being mechanically ventilated and transferred to this particular facility in Florida, where the individual was treated at 165 feet, table 6A. The inside attendant was breathing 50-50 nitrox while at pressure, which is obviously very good. On the way back at 30 feet, the injured diver suffered a sudden onset of VFib and was required to be urgently decompressed so they could defibrillate the diver. The diver actually did not survive this event, sadly. But the inside attendant now is brought back to the surface suddenly without the strategies to mitigate against decompression sickness in terms of O2 breathing. She was at the surface for about 6 minutes. They had her on oxygen during that period, and once they were able to get the individual out of the chamber and to clear the area, she was put back into the chamber and recompressed to 30 feet as a sort of omitted decompression protocol, where she received 3 cycles of 60 oxygen, 15 air. She came out of the chamber after that period exceedingly tired, which was probably not too surprising. She'd been in that chamber for about 10 or 12 hours, and she went home. She went home on her own, without any what we would think reasonable interval of observation at the hospital in question. She was found several hours later at home with complaints consistent with cerebral and spinal cord decompression sickness. She was brought back to the hospital. She underwent a very aggressive course of HBO therapy, had an incomplete recovery, and was proven to be career-ending for that individual. So the dread of the inside attendant in these cases is getting a high inert gas loading exposure and then an unscheduled decompression. So what should be the recompression protocol for someone that undergoes that? There are no consensus standards available. One might be guided by the U.S. Navy's surface decompression breathing oxygen protocol when they go back to 40 feet, but there's again no standards here. If the chamber, there should be some strategy protocol in place at the hospital. If the inside attendant comes out inappropriately because of a need to decompress the chamber, or the chamber's physically not able to stay under pressure, then what do we do with that inside attendant if the chamber is not serviceable? Where does that inside attendant go to be treated for presumed omitted decompression? These are all things that multi-place chamber programs have to think about. This next report comes from Bergen, Norway, and this group reported their initial inside attendant DCS experience at a European hyperbaric meeting in 1997. Their dosing protocol was the common 45 feet of seawater for 90 minutes O2 breathing for the patients, and the inside attendants accumulated a total bottom time of approximately 110 minutes, depending on how quickly they were able to get the patients to pressure. There were 18 inside attendants over 1,500 sessions over a 30-month period, and they found that there were 3 cases of decompression sickness in the first 395 sessions. The staff members were breathing oxygen only during the decompression. The incidence based on that number of cases was 0.76%, but again, calculating individual risk, it was 17%. So what they did is they added oxygen breathing during the isobaric phase, the latter isobaric phase of the treatment, either 5 or 10 minutes, depending again on how long it took them to get the chamber to pressure. And with that additional oxygen breathing during the isobaric phase, in the next 1,100 treatments, there was 0 incidence of decompression sickness. But a couple of years later, confidence in that additional O2 breathing quickly collapsed when a very serious case of decompression sickness occurred in one of their nurses. This led them to investigate a series of decompression options that might be available to them to help mitigate. They recognized very readily that the ultimate evaluation of any profile is the actual occurrence of decompression sickness. That's the measure, of course. They also recognized that it would take an enormous amount of data to test every single decompression option against the incidence of decompression sickness. They felt like they'd all be retired before they got sufficient data. So what they elected to do was to study inside attendant decompression stress rather than decompression sickness via venous gas embolism detection with Doppler devices as a surrogate to decompression sickness. And they actually looked at 3 decompression schedules. The first one was the current practice that actually added a couple of minutes, you can see there, to 12 minutes of oxygen breathing during the terminal isobaric phase and throughout the ascent. They had then what they called the enhanced oxygen option, which was a doubling of the O2 breathing period at the isobaric phase and then during the ascent. And then, quite impressively, they had inside attendants cycle nitrox, 40% oxygen in nitrogen throughout the entire isobaric phase. And then they had the air breathing during the ascent. And what was quite fascinating was that venous gas embolism scores were identical to all 3 protocols. You would think that as we increasingly added oxygen breathing, you would add a measure of protection, but this was actually not found in this particular study. So they noted here that all future elective treatments will be provided in monoplace chambers. They didn't have any, so they had to quickly buy, they bought 4 chambers, 4 monoplace chambers, and started again treating all their elective patients, reserving the multiplace chamber for sicker patients. So you see there's been an evolution of decompression procedures for the inside attendant over about 5 decades. This evolution is entirely empirical, entirely based on trial and error. There's been no real concerted science and formal study to compare and optimize protocols. So again, listed here are that evolution initially with the inside attendant coming back on a standard air decompression table, adding a safety stop as is common in the beginning of the 1970s in recreational diving, slowing the decompression rate breathing air for the inside attendant, eventually adopting oxygen breathing during decompression, and then O2 breathing during decompression while slowing the decompression. And then in that last box there, adding O2 breathing during the isobaric phase of the treatment and then during the decompression. Continued here on this next slide, one has increased the period of oxygen breathing during the isobaric phase and then the decompression. They've rotated, as you saw, inside attendants if we have sufficient staff members available. Nitrox and air breathing cycles during the treatment phase, as well as nitrox throughout the treatment phase. That's a little bit convoluted. As you move around in the chamber with a bibs mask on and hoses, you've got to keep disconnecting the hoses from one outlet and moving it to the next one as you move around a relatively large chamber. Then we have, you saw that oxygen breathing during the initial period at the isobaric phase, plus the latter phase and decompression. And then finally, and somewhat controversially, is limiting inside attendant in the multiplace chamber on an as-needed basis, i.e. leaving all the patients in the chamber alone without an attendant and only having the inside attendant enter the chamber if there was a need to do so. And when they would do that, the inside attendant breathed nitrox. And the basis for that actually was this survey by the Danish Agency for Safety and Health at Work. They noticed, amongst other things, that working in a hyperbaric chamber is particularly risky. They had the top 10 most dangerous professions in that country, and the inside attendant came out at number 8. Number 1 was mixing explosives, as you might imagine was quite dangerous. So based on that concern, the group in Copenhagen, they decided to, as we saw, to limit the inside attendant on an as-needed basis and have them breathe oxygen, nitrox, I beg your pardon, while they were in there. That's the only center that I know of that actually adopts that rather extreme position. So, recommended procedures for decompression. We saw the US Navy has them down very well for decompression sickness. For gas gangrene, Clostridium myonecrosis, and CO poisoning, the prevailing data shows that 3 ATA is the desired pressure, certainly with CO poisoning for the first treatment. So how do we protect against decompression sickness at the 3 ATA profile? Well, the options here are, again, to rotate inside attendants to limit the amount of nitrogen uptake. If you don't have enough staff to do that, then nitrox breathing, either intermittently or throughout, would be another very protective measure. And if we don't have nitrox available, then O2 breathing during the latter stages of the isobaric period, and that breathing period of oxygen is not well defined at the moment, plus the decompression phases. So that would be 3 steps there to help mitigate at that higher pressure of 3 atmospheres absolute. For all other common indications, the treatment pressures typically range from, in the multiplace chamber, 2.36 to 2.5 atmospheres absolute, 45 to 50 feet of seawater. And arguably, the single greatest measure to limit or certainly limit and possibly eliminate DCS is to treat these patients at 2 ATA oxygen. Okay, and we mentioned that a few moments ago. The reason why most chambers are at 2.36 or 45 feet of seawater is the mismatch between oxygen provided through an oral nasal mask and the chamber pressure itself. At a chamber pressure of 2.36 ATA, breathing from an all-nasal mask, the patient's probably getting around 2 to 2.1 ATA oxygen. And again, a lot of the establishing data for certainly the wound healing side of the equation was conducted at 2 ATA oxygen. So increasingly, multi-place chamber programs have actually dropped the pressure from 2.36 or 45 feet of seawater to 2 ATA if they have hoods for the patients where they know they're getting essentially 100% oxygen. And if we go to 2 ATA in the chamber, oxygen, and have the inside attendant breathe oxygen during the terminal isobaric phase and the ascent phases, we should really almost zero out inside attendant decompression sickness. Now, if there is resistance to dropping the chamber pressure to 2 ATA with patients in hoods, then the decompression protocols for these attendants should be really in accordance with the gas gangrene CO protocol of rotating tenders, nitrox breathing, or extended periods of oxygen breathing at the isobaric phase and during the decompression. And the final aspect of all this is that the institution, the hyperbaric physician team, and the individual inside attendants have to bring something to the equation. The onus is on those bodies to bring something to the equation. So pre-employment fitness to work in pressurized settings should be undertaken. At the moment, there are no screening standards consensus standards to how to evaluate fitness to work in pressurized settings. In a recent survey sent out by the BNA to inquire about inside attendant decompression sickness, a surprisingly high percentage who reported back said they never underwent fitness to work in pressurized setting health screening before they were employed as inside attendants, which is obviously very disappointing. There needs to be periodic rescreening. How frequent? Again, that's not something that's really well teased out at the moment. One intuitively would think at least annually, but then we don't know enough to say that's a firm recommendation. And then any rescreening that might be considered necessary following illness or injury, particularly illness or injury that might predispose to decompression sickness. Then, of course, for the inside attendant, there needs to be an obligation to maintain general well-being, i.e. cardiovascular fitness to some degree, a reasonable body mass indices, and other things that generally will make the person a much better risk to undergo uneventful decompression. And then pre-exposure fitness. Each time the attendant goes into the chamber, ideally they should be well hydrated, they should be well rested, and they should report any acute change in healthcare status before they go into the chamber, because if that's existing when they come out of the chamber, obviously differentially it might be difficult to decide whether indeed that was a pre-existing condition or something as a consequence of decompression itself. And some other thoughts. Then there really needs to be a mandatory post-chamber exposure on-site observation period. We saw that in Joyce's case. She was allowed to go home quite symptomatic. She was consistent in her complaints with pulmonary manifestations of decompression sickness, but was allowed to go home. There needs to be some defined period of observation before one is allowed to go home, particularly home alone. And there needs to be a mandatory reporting of any acute change in healthcare status coming out of the chamber. That person then needs to be evaluated and diagnosed with that, whatever that complaint is. Certainly in terms of any altitude exposure, commercial airline travel, there needs to be an interval. A common standard is 24 hours before flying or the like after coming out of the chamber. And in the 3 publications that reported no incidence of decompression sickness inside attendants. What was unique is that there was a limit on the number of weekly and or consecutive exposures an inside attendant could undergo. It was 3 or 4 and not 5, typically Monday through Friday programs that might go. We should also make every effort to avoid scheduled repetitive dives, 2 dives in the same day. If there's a mass casualty, mass poisoning, CO poisoning, we can't always enjoy that luxury of not having a repetitive dive, but they certainly should not be scheduled. And again, my favorite is there should be a minimum chamber pressure necessary to produce the desired therapeutic effect. And I think for the wound healing deficient patient, 2 atmospheres oxygen is that pressure that will produce that effect. And if you have a hood in the chamber, then the chamber pressure can be 2 ATA. If you have a mask in the chamber, then of course the chamber pressure of 2 ATA would not necessarily produce an oxygen pressure of 2 ATA. In closing then, what's unfortunate about all of this is that inside attendants have not really been afforded the same level of safety oversight enjoyed by healthcare worker colleagues at risk for such things as blood-borne pathogens or chemical hazards or damaging radiation. Certainly in terms of establishing exposure limits, health screening standards that I just alluded to, and incident reporting. In this environment, inside attendant DCS continues to occur, occasionally as you saw, with career-ending consequences. That it is underreported, it certainly is, serves to underestimate the risk and so deflect attention from an otherwise deserving employee cohort, and that's you guys. All of this, in my view, represents a strong argument to formally address inside attendant health and safety. And one approach might be to develop a population-based longitudinal study, say in the form of a robust registry. Ideally, it would be international in scope and would want to include some outside, i.e. non-HBO people, whose remit extends to safety in the workplace. If we could pull this off, it would serve to better identify risk factors that might prompt the presently lacking consensus health screening standards. Optimized decompression procedures would likely to be another benefit. In a perfect world, the sum of all this would be a healthier work environment in which to improve the well-being of patients deserving of the unique therapeutic tool that is the hyperbaric chamber. Thanks very much for listening.